Hello, everyone. It's Dr. Bill Saxon here, and I'm looking forward to spending the next hour or so kind of reviewing some information on how to accurately diagnose infectious diseases, some of the ones we see commonly in practice. And we're going to be highlighting the advantages of polymerase chain reaction, or PCR, in helping us get to a diagnosis quickly and accurately in our patients. So let's get started here. We'll just jump right in. Here's kind of what we have in store. We're going to kind of talk about what it takes to diagnose an infectious disease, the different kinds of methodologies, what's unique, different, and advantageous about PCR testing, and go over some updated recommendations for the use of PCR testing with various infectious diseases. So let's buckle up and get rolling here. All right, I think the first thing is to highlight that when it comes to definitively diagnosing, ruling in an infectious disease, it's a two-step process. First, screening for the disease, and if our screening test is positive, then confirming that positive result with a confirmatory test. So with the screening test, we want to know if our patient could have the disease. These tests are ideally quick and expensive and able to be run PET-side. And the methodology for most screening tests is serology for either antigen or antibody. And we'll talk about that briefly. The key feature of a good screening test that it has is that it has high sensitivity. And this means very few false negatives. So if you get a negative result on a good screening test, you can confidently rule out the disease. All right. However, if the result on a screening test is positive, you need to go further to confirm that infection. So a confirmatory test, as opposed to a screening test, is done on a patient who has had a positive screening result. And now we want to know if this particular patient actually has the disease. So we only perform confirmatory testing in patients that have a positive screening result. And these sometimes are more involved, sent out to the reference laboratory, perhaps more expensive. And the most common methodologies for confirmatory testing are ELISA, antigen testing, and PCR. Okay, and we'll talk about why those methodologies are better for confirmatory testing as we go along. The key feature of a good confirmatory test is that it's highly specific, because high specificity minimizes false positives. Therefore, if you get a positive result on a good confirmatory test that has high specificity, you can confidently rule in the disease, okay? So important to keep that in mind, but the key here is that to confirm infectious disease is a two-step process. First, screen, follow up any positive screening test with a confirmatory test. Now, these statistical terms I think that we're most familiar with are sensitivity and specificity, and to keep it simple, you just want tests that have higher sensitivity and specificity. The higher, the better. And as we mentioned, high sensitivity means that the test is going to yield few false negatives. So you can trust that a negative rules out the disease. Cat comes in, you screen for FELV, your FELV snap test is negative, move on. The cat does not have FELV. If that screening test comes back positive for FELV, we need to confirm. With a highly specific test or high specificity, you're going to end up with few false positives. Therefore, you can reliably confirm a diagnosis with a highly specific test. Okay, so we'll talk about how that factors in as we move along. Just to show you some numbers, again, with sensitivity and specificity, the higher, the better. So if you have a choice, pick the test that has the highest sensitivity and specificity. And among the tests shown on this slide, the SNAP FELV FIV combo test has the highest sensitivity and specificity for FELV, which is a big advantage, meaning you're going to have more accurate results, fewer false negatives and fewer false positives. You can see that the difference in sensitivity and specificity for FIV isn't that great. Most tests for FIV are pretty good these days. In fact, so good that a positive test usually confirms the disease. All right, we have other options, PCR, as we'll discuss. But with FELV and specifically, we really do have differences in sensitivity and specificity reach for the test that has the higher numbers, and that would be the SNAP test. Okay, so a little bit more of a deep dive, if you will, into the test menu that we have available for infectious diseases. Serology, again, is our most popular and commonly used screening methodology. And there are different types of serologic tests. The SNAP tests are ELISA methodology, but there's immunofluorescent antibody, IFA, and microscopic agglutination titers, MAT. And again, the key for a good screening test is high sensitivity. Confirmatory tests are usually nowadays molecular in origin. And we're going to talk about polymerase chain reaction, PCR, today. The FISH, the fluorescent in situ hybridization, is another molecular technique to identify infectious organisms in tissue. And that's will be the topic perhaps of another lecture, okay? And then with confirmatory testing, again, we're looking for high specificity, so we have very few false positives. The minimum laboratory database, consisting of a complete blood count, biochemical profile, and complete urinalysis, could also be considered and should be part of the menu of testing for infectious diseases, because sometimes the only way you'll identify active disease is by changes in your minimum database. And you can also there as well assess for extent of disease. Is there, say, kidney involvement with vector-borne disease? Is there severe anemia with some infectious diseases, etc.? So useful to include the minimum database, especially when we're trying to determine if our tests for infectious diseases, our positive results, are truly indicative of current disease, and if so, how severe the disease is. Serology can measure either antibodies or antigens, and it's really important to know which your test is identifying because it tells you different things. Antibody, obviously these are produced by plasma cells, and they are the response of the immune system, humoral immune system, to a foreign antigen. The key about antibody production is that there's a lag time. Just think about on average 10 to 14 days between when an animal is exposed and produces detectable antibodies. There's a lag time there. Antigen, serologic tests for antigens, they're actually looking for the organism or part of the organism. So it's actually identifying the bug, all right, versus sort of an indirect indication of exposure, which is what the antibody response will show. And then the titer is just a level of how much or the amount of antibody or antigen. And I just want to refresh everybody's memory on how to interpret these titers. So this is a leptospirosis panel of titers, microscopic agglutination titers, and you can see that there's varying numbers here. And the question is, which is the highest titer? And it's to L Grippo, greater than or equal to 1 to 12,800. Okay, so just look for the highest number after the colon. And I point this out because some veterinarians do math. They think that they need to divide, say, 1 by 12,800 to get the titer. And if you divide, you're going to get the complete opposite result. Okay, so don't do any dividing, don't do any math. Just look at the number, the highest number to the right side of the colon, that's the highest titer. Okay, so what do positive results for antibody mean? So when you have a positive antibody response, it means that the animal's been exposed to the organism. That's all you can say for sure. That might indicate current infection. It might indicate past exposure. It might indicate you treated the animal and there's a persistent titer, and there might be even some organisms still there. It might be that you've treated the animal and it's cured and the titer just hasn't decreased yet, all right? All you can say with certainty when you have a positive antibody titer is that the animal's been exposed to the pathogen. A negative antibody titer usually means no exposure. However, again, there's that lag time. It takes a couple of weeks to mount an antibody response. So with acute disease, a negative might just mean that you haven't had time. There could be infection, but there hasn't been time for the antibodies to be produced. Compare that to what the positive antigen test means. This is actually a part of the organism. Think FALB again, the P27 viral antigen. A positive antibody test means you have the organism there, you found it, okay? And a good antigen test, a highly sensitive antigen test that is negative, means you have no infection. It's possible that there could be such a small amount of antigen that you wouldn't be able to detect that with your screening test, but that's uncommon. Okay, so digging into a little deeper what positive and negative antibody results mean, because this is important. And this is one area where PCR testing can eliminate some confusion, as we'll get to. Again, all you can say with certainty when you have a positive antibody test is that the animal has been exposed to the organism you're testing for. That's it. Did the immune system clear the infection? Great, no infection, just a titer that is the antibodies that were able to clear the infection. Could be current infection, could be treated and residual infection, could be treated and cured with residual titer. And then vaccines can interfere with the antibody titers, right? And can be measured, cross-react with the antibody titer in the test. So positive antibody titers, as doctors, we have to do work to determine, does this mean our patient in front of us now has active disease? And this is where your physical exam, history, and your minimum database will be helpful. A negative antibody result usually, again, means no infection. However, it could be acute infection before seroconversion in that first week or two after exposure. There could be low-level infections, so not enough antibodies produced to detect that infection. There could be something going on preventing the animal from mounting an antibody response, immunosuppression from either disease or treatment, such as immunosuppressive doses of corticosteroids. And then antibodies and antigen are part of the humoral blood circulating immune response. There's another type of immune response, the cellular immune response. This is the domain of lymphocytes. This is what mostly is effective against viral diseases. So if this particular infection is mounting or inciting a cellular immune response, a negative antibody titer might not you might get negative antibodies because they're not being produced, yet there's an effective cellular immune response. Okay, again, the whole point here is that you have to interpret antibody titers in light of stage of infection, clinical signs in your patient, and laboratory results to make the decision of whether there's current infection or not. So as an example, let's take a look at our SNAP4Dx Plus test and look at which of these tests, organisms, are antibody and antigen titers. So all of the Ehrlichia and Anaplasma species are antibody tests. So they follow the rules that we just talked about. Lyme disease or Borrelia burgdorferi, which is present in Brazil these days. It might not be as common as it is in the United States, but it is there. The antibody test for Lyme disease is more similar in its interpretation to an antigen test, because the antibody test for Lyme disease, the C6 antibody test, is only produced when the organism is actively dividing in the dog, meaning the dog is infected with the organism, and it is not affected by vaccine for Lyme disease. So you can look at a positive SNAP result for Lyme as an indication of active disease, okay, which is a little different from the other way to interpret antibody tests that we've talked about, but it's a very specific feature and beneficial aspect of the Lyme C6 antibody test. And then the heartworm test on the 4Dx Plus is an antigen test. Therefore, a positive means animal has heartworm. Negative means, because it's a sensitive test, that the animal likely does not have heartworm disease. Okay, so just to reiterate what a positive result on a SNAP4Dx Plus means, and this is whether it's a sick patient or a healthy animal, and we should be screening healthy patients for vector-borne disease because often there are no clinical signs, and the only way you'll identify the disease is by screening and then looking for evidence of infection in your minimum database. Think low platelet count, thrombocytopenia, think proteinuria, okay, possibly anemia, high globulins, okay? So if you get a positive for Anaplasma ehrlichia, all you can say is, yep, that dog has been exposed to that organism. Then you have to go through the process we talked about to determine if that indicates active disease or past infection or residual titer, okay? With the positive Lyme, you have active infection and no cross-reaction with vaccine. So you know that that animal currently has Lyme disease, and then you need to decide whether you should treat that based on other parameters like a quantitative C6 titer, any evidence of proteinuria. And the urinalysis, for example, would be potential tools to determine whether you need to treat that Lyme patient or not. And then because the heartworm test is an antigen test, if you have a positive for heartworm, dog has heartworm. Okay. Okay, so that's the serologic sort of review. And now let's talk about what we're really here to talk about today, which is polymerase chain reaction, how this is really a helpful tool and is going to be used increasingly for more infections in more ways going forward. So let's just dig into that a little bit. So what it means is polymerase chain reaction. What this tests for are specific portions of DNA, mostly, sometimes RNA, of a pathogen. So a very, very specific, exact DNA marker is what this detects, meaning that very high specificity. Okay, a positive PCR for whatever organism you're testing means that that organism is present in the sample. And it's also a very highly sensitive test, meaning that if you have a negative result, there are chances of that organism being present are very, very slim. PCR is so sensitive, it's reported to be able to detect as little as 1 to 10 organisms. Okay, so very sensitive. And the reason that it can detect such small amount of DNA, so few organisms, is because the way IDEXX runs PCR testing is called real-time PCR. There's an amplification process. So every sample goes through many cycles, 45 cycles, with the amount of DNA doubling in each cycle. So by the end of all of this, we've got trillions of copies of DNA. All right, therefore you can detect very small initial amounts because of this amplification process. This type of PCR is also sort of like the newest wave of PCR testing. It's very likely to have any sort of contamination. It's a closed system. It's got very tight quality controls. It is really a game changer in terms of how accurate PCR tests are. In the old days, with more open systems, DNA floating around in the air could land in your sample and could contaminate it and not give you any clue about what was really present in the patient you're trying to look at, right? And we can also quantify the number of organisms or the amount of DNA, which is, as clinicians, can be very helpful. And there's a whole raft of quantitative PCR results. And the benefits of quantification are it can tell you how much organism is present, and that can be really helpful in making treatment decisions, especially in animals that have been vaccinated. So some modified live vaccines will be detected by PCR. And if you have, say, a puppy that has signs of distemper, and it's also being vaccinated for distemper, and you want to know if you have actual distemper disease or not, you could run a quantitative PCR. And above a certain cutoff, you would be thinking, oh yeah, active disease. Vaccine levels are lower than infective levels. So we establish a threshold, and if that puppy has the amount of DNA copies above the threshold, that dog has distemper. If that DNA amount is lower than the threshold, that is due to vaccine. So it can be very helpful. And also, as we'll see in a minute, in determining the stage of FELV infection, being able to quantitate the FELV PCR test, super helpful. And it can also guide therapy with leishmania. We'll get to all of that. So as an example, we have a quantitative PCR test for leishmania. That's if it's done on blood or bone marrow, and this can determine the parasite load, and that can help you determine whether or not you need to treat, okay? So we are kind of going through what the advantages of PCR testing over serology is, and two of them we've already discussed. It's very highly specific and it's very highly sensitive compared to serology. And because with antibody testing, serology testing, there's that lag time before you get a positive, PCR allows earlier diagnosis before antibodies are produced in some infections. So another advantage of PCR testing is you can diagnose them in that acute phase. Now, sometimes in order to get the most complete assessment, you need to do both PCR and serology, because you never know exactly where your patient is in terms of their exposure to the pathogen. But early diagnosis is another advantage of PCR testing. All right. And again, there's no one test that is always going to give you the answer for infectious diseases. And there are times when, if the first test you run, serology, is negative, adding a PCR may give you the diagnosis, and vice versa. Okay. This is especially true with vector-borne diseases. all right? And sometimes you got to repeat the test. Again, no test is 100% sensitive and specific all the time, all right? And the behavior of the organisms can change. Sometimes they're circulating, sometimes they're not. Some organisms are better at eliciting an antibody response than others. So there are times when, in one particular study, a single PCR, for example, was diagnostic in 80% of the cases. If 2 consecutive PCRs were run, then 100% of diagnoses were made. So just be prepared that it can get complicated, especially with vector-borne diseases, right? Because those organisms tend to hide in bone marrow and spleen and other tissues, not always in the blood. And sometimes they're chronic and low levels, so they can affect the accuracy of both serology and PCR. So it might be necessary to do both and repeat both. But luckily for us, that's usually not the case. Okay, so let's talk about some specific diseases where PCR testing has really helped us as clinicians help our patients, which is kind of the whole goal, right? So we're going to talk about, in feline viral diseases, how PCR can help us with retroviruses, FVLV, FIV, and now feline infectious peritonitis virus, or FIP. Best place to kind of get an update on current recommendations for all things related to feline retroviruses are these 2020 AAFP updated guidelines. And here is where you can find all the information in great detail that we're going to touch on here tonight. All right, cat gets exposed to FELV. Most of the time, believe it or not, the immune system of the cat mounts a very strong response and clears the infection, an abortive infection. Some cats get infected. What happens at that point? So they would be positive on your SNAP test, okay? What happens to that cat will depend on the immune response of that cat. This is new information, and this is where the PCR test for FLB can be very helpful. If the immune response is weak, then the virus will spread, go through all stages of infection. That cat will be persistently, progressively infected, infectious to other cats, develop FVLV-related disease. Okay, this is a progressive infection because the cat's immune response couldn't contain the infection. If the cat mounts a stronger immune response, not strong enough to clear the virus, but strong enough to hide the virus in the viral DNA, in the DNA of the cat, then we have what's called a regressive infection. The cat's infected, but only at the DNA level. There's no active virus circulating. The cat's not infectious to other diseases. It's not sick, okay? So the immune system has determined that, but the key here is that the immune system can change. If the cat, say, whose immune system is able to control the disease in this regressive stage, where there's only DNA of the virus in the DNA of the cat, cat's living a perfectly healthy life. Let's say as it gets older, it gets immunocompromised from having, say, lymphoma or being given high-dose prednisone for inflammatory bowel disease. That can diminish the immune system, weaken it, and that cat can revert to a progressive infection. So how can we stage that cat? How do we know whether that cat who's positive is progressively infected or regressively infected? We do a quantitative PCR test for FELV. And there's a cutoff, right? That's the point of the quantitative aspect. Establish a cutoff, and the number of copies that are, if the number of copies above the cutoff, that's active progressive infection. If the number of DNA copies is below the cutoff, that's a regressive infection. The key, though, is that if the immune system changes, the cat's stage can change. And this explains why those cats you've seen that have results that are sometimes positive and sometimes negative, we tend to think there must be a mistake at the lab or the test isn't right. It could just be that the cat's immune system is sometimes controlling the infection, sometimes it isn't. This is also the rationale for why any sick cat needs to be tested for FELV regardless of prior status. No previously positive SNAP test for this cat, lives indoors, no other cats, no other problems, and then it gets sick. Should you repeat the FELV test on that cat? Yes. Why? Because maybe the cat being sick has affected the immune system, and now the cat has is no longer able to control that infection in the DNA regressive level, and that cat's reverted to a progressive infected cat. Really new information. And again, we're covering it sort of briefly here. All the details are in that AAFP guideline document that I showed. Okay, what about PCR testing for FIV? Also available, the only FIV PCR test validated by independent studies is the IDEXX PCR. And like all PCRs, it's highly specific. Okay, so a positive FIV PCR that you might run on a cat that's, you're not sure whether it's been vaccinated, for example. So the vaccine for FIV will cause the SNAP test, which is an antibody test, to be positive. You want to know if that cat truly is infected or has been vaccinated. That would be, say, one indication for running a FIV PCR. And a positive, you've got actual disease, because the PCR for FIV does not pick up vaccine. All right, so the vaccine doesn't affect the PCR for FIV. The sensitivity for FIV is pretty good, but the problem with FIV in general, the reason there's no antigen test for FIV like there is for FELV is because infected cats have very low viral loads, okay? Hard to detect by antigen serology and also by PCR. So the most beneficial use or result of a PCR for FIV is when it is positive to confirm infection. A negative likely rules it out, but again, there could be such small numbers of viruses in that cat that no test can detect it, okay? It is available, it is useful, okay? Now, the other newer application for PCR testing for cat viral infections is for diagnosis of feline infectious peritonitis, or FIP, which, as we know, is really hard to diagnose. Coronaviruses in cats come in two types: the sort of benign enteric one that lives in the intestine. Most cats have this. It causes no problems in the majority of cats. However, when this enteric coronavirus mutates, it becomes the infectious peritonitis virus. This mutation allows it to develop tropism for macrophages that then can then carry the virus outside of the intestinal tract, leading to granulomatous disease, granulomatous vasculitis, which can cause either the wet or the dry form, okay? And neurologic involvement can be seen in either. And this has been a fatal diagnosis until recently, and now we know there are RNA transcription inhibitors that can be found on certain websites that really are effective at curing this disease. But where does the PCR test come into confirming the diagnosis of FIP, which is really hard? Well, we start with suspecting that the cat has the disease. So this is sort of our pyramid of leading us toward a diagnosis of FIP, and now we have PCR at the top that can actually confirm it for us. Okay, so we would start with, we have a cat that has the right signalment, younger cat, the classic nonspecific signs, something on our history physical makes us think FIP. We start then by evaluating our minimum database. Do we see any kind of changes? Again, none-specific for FIP, but getting this in the ballpark. Say if we have a low albumin to globulin ratio. So high globulins, low albumin, a ratio of less than 0.9. Some people say 0.8, some people say 0.5, but a decreased albumin globulin ratio that can, get us thinking about FIP. Titers, coronavirus titers, are not very useful. I'm not a big fan of those. And then the next would be, do we have, actual effusion of the wet form, either chest and or abdomen, that's high in protein, low in cells? Another thing that would make us think this cat has FIP. With the dry form, do we feel granulomatous changes in the intestinal tract, perhaps? Do we see retinal lesions? All these things that are pointing us toward FIP. Now we have a PCR test that can give us the answer in these cats. And what this PCR test for FIP does is it detects the mutation that enteric benign coronavirus has undergone to now become the pathogenic FIP virus. All right, so this only will be positive if you have the mutated pathogenic virus. It detects most FIP strains. Okay, not all mutations are in this spike gene, so this test will not detect every mutated form of coronavirus, but over time, as other mutations are identified, additional FIP-PCR tests or expanded mutation detection will be possible, allowing us to detect these other strains. So we have now a PCR test that can help us sort of confirm the diagnosis of FIP. And this one, we perform it only on body cavity effusions in wet form or tissue biopsy or aspirates in the dry form. This is not done on blood. Okay, so news on FIP testing related to PCR. I think you're probably familiar with PCR testing for Leishmania. And again, quantitative PCR is really helpful, run on bone marrow or whole blood at determining the degree of parasitemia, and it helps us determine if we have active disease or like carrier reservoir state, which also helps us determine transmission risk. We can also use the level of the PCR result to determine if treatment is effective. We can also run the Leishmania PCR on other samples, on tissue, urine, and other species. In that case, not quantitative, just positive or negative. And again, if we're not getting an answer for Leishmania with our standard SNAP tests, nothing on our lab work is consistent or specific, and we're kind of scrambling around, we're not getting results for positive PCR on whole blood, we can run this test on marrow, lymph nodes, spleen, skin, etc. Things where tissues where this organism can sort of remain in a reservoir hidden state. And it's a very specific, as all PCRs are, for this organism. It doesn't cross-react with other similar organisms, okay? And you can look at an algorithm just to sort of work us through how we would use and when we would consider PCR testing. Again, with infectious disease, it's a two-step process. We screen first with a serologic test, and if that test is really good, a negative rules out the disease. Now, again, in some instances, especially if it's an antibody test and the infection's at a low level or in a chronic state, a negative wouldn't necessarily rule it out. Or if it's acute, you might get a negative result. If you get a negative result in that setting, you would want to continue to pursue possible infection that's either acute or hidden by looking at your minimum database and considering running a PCR test, okay? If the SNAP test or screening test is positive for Leishmania, absolutely the next step to determine if that is true and quantitate the level of infection, we would run the quantitative Leishmania PCR. And if that comes out to be negative, then we have to consider potentially other diseases, maybe look for Leishmania in other tissues, skin, other tissues. And then if that positive SNAP test is followed up by a positive quantitative Leishmania PCR, then you've confirmed the diagnosis. With that level, you can determine what stage, what treatment, whether treatment is necessary, and then you can monitor response to treatment by following up, doing serial PCR tests, okay? There's also PCR for leptospirosis, which can be very helpful because leptospirosis can present acutely. The dogs come in classically with acute kidney and liver problems, so before serology would be positive, before antibodies would be performed. So in that acute stage of leptospirosis, PCR testing can be very helpful. And we run PCR for lepto on both whole blood and urine. And the reason for that is in the first week of infection, the organism circulates in the bloodstream. So if we run the lepto on whole blood, we can detect the infection in that first week. Again, one of the advantages of PCR testing is early diagnosis before seroconversion, right? So this is an example of that. After a week or so, then the organism is shed in the urine. And again, sometimes we don't know exactly where the animal is in the stage of infection, so we would recommend doing the PCR test on urine and whole blood. This is not affected by vaccine, as most serologic tests are, so very useful to consider in vaccinated dogs for leptospirosis. Can also be used to monitor effective therapy. So at the end of your 2 weeks of doxycycline, running lepto-PCR on urine can help you determine that you've cleared that urine shedding phase of the organism, so that there's no longer a zoonotic potential. And again, Just to remind you, it sounds really straightforward, where we're going to just do serology and PCR, and we know the advantages, and we'll have an easy time to make a diagnosis. Sometimes, especially in sick animals that can be in various phases of diseases, running both might be necessary to get a diagnosis, and including minimum database findings to determine extent of disease and active disease. And again, repeating these tests may also be necessary in certain instances to secure a diagnosis. So let's finish up by looking at a couple of cases just to kind of review. I don't know if my video is in the way here. I'll try to move it. I'll just move me out of the way. Okay, there we go. So we have Jackson here. Jackson's a 7-year-old neutered male lab. He comes in with a complaint of lethargy and panting for 2 days, so acute presentation. And in addition to those findings, he's got a decreased appetite, no vomiting or diarrhea, recent exposure to a tick, swims in a nearby lake, otherwise in pretty good shape. Physical exam looks pretty good, except that he's a little quiet, and then walks gingerly and sort of generalized pain on limb palpation, something in the cranial abdomen, perhaps splenomegaly, seems a little bit out of the normal, abnormal as well. So we have low-grade increase in temperature, quiet responsive dog, lameness and splenomegaly. I think you know where we're going here. So it definitely fits the bill, especially with that tick exposure for tick-borne disease, right? So we're going to screen, right? We want to screen this dog with potential disease with a serologic test that's highly sensitive, and the SNAP4Dx Plus fits the bill and results are negative. So does this rule out tick-borne disease? No, right? Because this is 2 days in. It's too early for this dog to have mounted an antibody response. Again, think 10 days to 2 weeks for that to happen. So this is where a PCR panel of vector-borne diseases would come in handy. And we consider running these panels in acute presentations like Jackson, also to detect co-infections, which are common. And we especially suspect co-infections when we either have an unusually severe form of a vector-borne disease, or we've given doxycycline for 2 or 3 days and we've not seen any response. Okay, those are the kind of classic, perhaps there's a co-infection in this dog. We can also use PCR testing to detect chronic and sort of occult disease when the organism is no longer circulating, but now hanging out in spleen, bone marrow, lymph nodes, other tissue. And we can use it to determine if our therapy has been effective. So Jackson had a vector-borne disease PCR panel and is positive for both Babesia and anaplasma. Okay, and anaplasma, this looks like a classic anaplasma. Those dogs come in acutely ill, a little febrile, painful, inappetent, all of that. So that all fits perfectly well. And in addition, though, we have a Babesia organism here. Now, when we have a positive result on PCR for a Babesia at this genus level, then we speciate and found that Jackson has Babesia canis, not Gibsonine. Okay, and that will be important because the treatment is different, of course. So we have a co-infection. And if we had just assumed that, okay, likely some sort of tick-borne disease, typical, straightforward, let's get him on doxycycline, see how he does, this would have been a dog that would not have responded, right? And at that point, we would have needed to do that vector-borne disease panel. But having a negative screening test when we expect a positive in this acute phase got us to do that PCR test quicker, got us our diagnosis quicker, and got Jackson on the right treatment, which is both doxycycline and imidocarb. Okay, so let's look at our last case. I think is a 5-year-old intact female domestic shorthair who was just found as a stray, and her new owners bring her into the vet clinic. And on physical exam, she's got some sores around her head and neck. Perhaps she's been in fights. She's got a murmur, covered with fleas, acting a little painful with a crouched stance. It has kidneys that seem a little bit enlarged, maybe the right larger than the left. So initial lab results, FeLV, FIV positive on an in-house SNAP. Now remember that the SNAP test is an initial screening test, highly sensitive and specific. So results are likely to be real, but all positives must be followed up with more confirmatory tests, which were done and results were confirmed. If either of these tests were negative, because the test is so sensitive, we could have ruled out the disease and not considered those further. So with these results in hand, our problem list is retroviral infection. She's got this murmur and she's got fleas, and maybe that's what's causing some of the crusting. So perhaps flea allergy dermatitis. So we want to get her on treatment for her fleas. We want to evaluate her further to see if the retroviral infections have caused any problems. And this is where your minimum database comes in. And what we'll be looking at here, of course, is whether or not she's anemic, which is the most common abnormality with feline retroviral infections you'll see on the lab work. And she is, but what's unusual about her anemia, I know these results are small, but she's markedly anemic and highly regenerative. So we would expect, so with retroviral disease as a cause of the anemia, for the anemia to be, it could be mild initially, it may eventually be severe, but almost always non-regenerative. So here we have a regenerative anemia, and that means we have either a bleeding patient or a patient that's hemolyzing. All right, those are the only two causes of regenerative anemia, hemorrhage or hemolysis. No evidence of bleeding, so hemolysis is more likely, and we have to determine why that is. Is it immune mediated? Has her retroviral status made her at risk for blood parasite, hemotropic mycoplasma infection? All right, and is the retrovirus contributing to the anemia by predisposing her to an infectious disease, or could it have triggered an immune-mediated cause? And the key here is, one of the things that you'll read when you look at those AAFP updated retroviral guidelines is that a lot of cats with retroviral diseases live a normal lifespan, and this is especially true for FIV. All right, so not every cat that's FVLV or FIV positive that is sick because of the retroviruses. So it's important, especially now that we know the lifespan can be normal. It's no longer a death sentence having these. It's important to try to define another treatable disease. And so let's look at what might be causing kitties' anemia. So here is where, because hemotropic mycoplasma is a common cause of hemolytic anemia in cats and can also trigger immune-mediated hemolytic anemia in cats, we want to screen for that. And by far, the best test for hemotropic mycoplasma is PCR, because you know how hard it is to identify those organisms on a blood film. Sometimes they're not even present. Sometimes they're present on the red cells, but they fall off as the sample gets to the lab. We think we see the organism, but it's some other artifact. It's really hard to identify. PCR solves that problem for us. Again, highly, highly sensitive and very specific. And we see that kitty BIM is positive for 2 of the 3 species of hemotropic mycoplasma. Now, Mycoplasma haemophilus is the most common one, and it's the one that in and of itself can cause anemia. The other 2 are sort of less pathogenic and seen more often in immunocompromised cats, like cats that have retroviral infection. So she fits the bill for a cat who's immunocompromised from her retroviral infection, which has led her to likely develop these hemotropic mycoplasma species infection. Now, they're all treated the same way. All these species are treated the same way with doxycycline. If her hematocrit had been dangerously low and she was clinical for the anemia, showing weakness, tachypnea, etc., I might have given her corticosteroids as well. But I try to start treatment with hemotropic mycoplasma with doxycycline only, because often that's all these cats need. And we don't really want to give a cat who's already immunocompromised by having retroviral infections immunosuppressive corticosteroids, which could further immunosuppress them. All right, so she responded well, her hematocrit normalized, and at that point, she gets managed as a retrovirus positive cat, meaning stays indoors, no other cats. When she's ill, she gets seen right away. She gets twice yearly physicals and at least yearly evaluation of her CBC, chem panel, and urinalysis. So really careful monitoring, good dental care, all the things, good nutrition to give her the best chance of having a normal lifespan. All right. So we did it. We made it through, and I just want to kind of just review here what we talked about. Covered a lot of ground. So remember, infectious disease diagnosis is a 2-step process. screen with serology, high sensitivity, to rule out, to minimize false negatives, and high specificity to minimize false positive. Initial screening, serology. Confirmatory testing is where PCR comes in, okay? Super sensitive and super specific as well. Exact segments of the DNA of the exact organism in question. Advantages of PCR testing: we might be able to diagnose the infection earlier before seroconversion. We can run panels for vector-borne disease, anemia panels, to determine if we have co-infections, which are common. And we can use PCR for monitoring response to therapy as well. Staging FeLV infection is a new use of PCR testing in cats, which is very helpful. PCR testing can be run on samples other than whole blood, which is the most common, as we discussed, and that's helpful in detecting infections that are not present in whole blood, which may be hiding in bone marrow, spleen, lymph nodes, etc. And then having the ability to have quantitative PCR results really, as clinicians, helps us determine which patients need therapy and if our treatment's working. All right, so with that, I think we're done. And thank you so much for spending time with us tonight. Thanks.
Até este momento pode ser qualquer coisa. O tutor disse, ele está letárgico, está diferente, mas é preciso mais informação. Por isso, os laboratórios de referência IDEXX oferecem os testes mais inovadores do mercado. Preenchemos lacunas com soluções exclusivas que revelam detalhes ocultos. Descobrem doenças mais cedo. Enxergam o que os outros não conseguem. E estamos sempre criando mais. Só com o mais avançado e completo menu de testes, você poderá montar o quadro mais completo dos seus pacientes. Descubra mais com os laboratórios de referência IDEXX.